So tuberculosis. So how would you detect tuberculosis in a patient presenting to the clinic setting? Let's say normally when the patients get admitted to the hospital because of TB, they are very cachectic, they are very wasted, thinly built personas, very dyspneic with chronic cough, with SOB. So that is the presentation when you go and see the patient, very wasted patient. Now when you look at the presenting complaints and the history of presenting complaint, you will find that they have they go under the pyrexia of unknown category. That means fever for more than 2 weeks, right? Fever for more than 2 weeks, evening pyrexia, the night sweats, the chronic cough may be associated with hemoptysis sometimes. So other than tuberculosis, what else is there for this PU or pyrexia of unknown origin, right? So there can be infective and non-infective. Infective is tuberculosis is one of the main things. Other things like malaria, those things normally only after you miss it becomes unknown origin. If you do not miss, it will not be. So then also you get non-infective causes. Non-infective causes, they are inflammatory. Mostly could be due to malignancy like a lymphoma maybe. So TB. So now how would we, so the normal respiratory examination regarding normal general examination regarding TB and the history, right? So history, first of all you had a history of the normal things. I will not go into details about the normal concern and stuff. So first of all, is there any exposure, any contacts, right? We have to ask about the constitutional symptoms we discussed before in this video, and any contact history, a chronic smoker maybe, exposure to dust, not dust, exposure to public crowded spaces, a previous TB infection, that probably could be main. Then that is previous TB infection. Right. Any other respiratory condition, respiratory conditions, the immunosuppression is mainstream. So like HIV or anemia of chronic disease, not chronic disease conditions, they get immunosuppressed, right? Or in any hydrogen, like on long-term prednisolone treatment for like nephrotic syndrome or something, malignant immunosuppressions, like in leukemia. Is it? I can't remember. Sorry. Okay. Then TB. Okay. Now you have this patient. We have asked about the history. So what are the examinations? So pyrexia. So there could be fever. If there could be anemia of chronic disease, could be pallor. So the oral cavity should be also checked, because normally TB is like the disease of a poor. Now we get consultants with TB also, but normally TB is associated with it's like a wasting. So normally with poor socioeconomic backgrounds. So that is important in social history for socioeconomic background and education. Poor socioeconomics and poor socioeconomic background. So the oral cavity. So if there's like any oral crushes or poor oral health, poor dental health, could be. And generally you can then go for the arms, right? In the arms you can check for this clubbing. TB clubbing could occur, but not that much like COPD. Like in COPD also you do not clubbing. So normally clubbing you get because of this lung reasons, cardiac reasons, or GI reasons. So lung reasons would be like this lung malignancy, this chronic hypoxia, these things. And for cardiac cases, mainly like valvular disease, infective endocarditis, congenital heart defects, those things. And GI also inflammatory conditions like like inflammatory bowel syndrome, celiac disease, those things. Finger clubbing, right? So what else in TB we had? Okay, general examination, yeah, right, those things. Now when we come to the respiratory exam proper in the TB patient, you have to complete the general examination. Okay, in that thing you can get in the inspection in the TB patient, the interstitial dyspnea, increased work of breathing, those things can be seen. And can check for this apical flattening. Apical flattening is detected by looking at from the, you have to go to the foot end of the bed and just do this little drama, and you have to get down to the eye level and look at the apices of the lungs, whether they have like infraclavicular flattening, or one side is moving less than the other. So that is about inspection. Then you can go for palpation. In the palpation you can check for like the tracheal deviation, of course, and this about the lymphadenopathy, and we can check for this expansion from the upper, middle and lower zones, from anterior and the posterior aspect. Then you can also check the percussion, could be dull on the consolidated areas. The auscultation also anteriorly and posteriorly with the axillae. So TB infection is most common in the upper and the middle lobes, because this bacilli is very lightweight, so it floats in the air. So there's low chance of it going down into the lower lobes, so more in the upper and the middle lobes. Also I think more in the right side, right? Can't remember why. So okay, now for the investigations. So we have a couple of investigations, and Mark 2 is at the last. Okay, Mark 2 is not the first. You can just go for a. So the most easiest investigation to do is looking for this acid fast bacilli in the sputum of the patients. So acid fast staining, this is a technique that uses this carbofusion, if I remember. So unlike like other staining techniques like the gram staining, this Mycobacterium tuberculosis, it is a typical Mycobacteria. So anyhow, it does not have this cell wall structure like the others. It has something, but not like the other bacteria. So what they have are mycolipids. So when you use this carbofusion and then wash it with acid alcohol, so in other guys the stain just gets washed away, but in the Mycobacterium tuberculosis, these mycolipids catches and keeps this thing, so the bacilli gets stained pink, this nice pink color. So and we just used 0.5% methylene blue to just get the background blue color. So that is the most easy thing you can do, right? Each sputum. So we use 3 sputum, so they are collected at the normally early morning one, then you store it in the normal fridge, 4 Celsius, right? I think. Then the next day, early morning sample and a spot sample when the patient comes to the thing. Or you can do an early morning sample. Then when the patient comes, then do a spot sample. Then wait for another hour. Then do another spot sample. That is the most correct method. But if the patient is not willing to come again and again, you have to somehow do. Okay. Yeah. So the method of collecting. I also have come. The method of collecting is a sputum sample. So you have to first wash your mouth. Then take a couple of deep breaths, like 3 deep breaths in and out. Then you have to just cough deeply and get a good, like 10 milliliters, yeah, just a good amount of sputum into a clean wide mouth container. Ideally should be sterile, but clean is enough. Clean is more than enough. So you should not just get a little bit of just get some spit, right? It has to be sputum. If you cannot induce sputum, then the easiest thing is to do some normal saline nebulization and get the sputum induced. So we can go for a bronchoalveolar lavage. That is just too much. The thing with the sit-fast bacilli, it is specific. It is not specific, right? Like it is sensitive, but it is not really specific. There are some other tuberculosis species. So other mycobacterium species. But the thing is, other mycobacterium can also be present in the sit-fast strain. But you need a large amount of bacilli in the sit-fast strain. So if you initiate the sit-fast strain and gets positive, then that is a good demarcator. But if it doesn't, then you would have to go for like a TB gene expert. It is a concept of a PCR technique. So there are 2 techniques that play here: TB gene expert or another thing. If you can just get a look at those things doing, it is a very nice procedure. They just get the sputum, add a liquid buffer, then get the sample, a little bit of a sample into another buffer. Then they just put this into this nice very cool looking extractor thing. Yeah, it has like I don't know whether you guys have seen a dialysis machine. So just like a roadmap of dialysis set. So there's this little card containing the path for this sputum sample to go, and at the final the DNA gets extracted to this point. Very nice DNA extractor cartridge. Then after extracting from this DNA extractor machine, the samples are put like 4 at once to this PCR machine. Yeah, also something before this is fine. Before we are starting TB drugs, we have to just get a baseline, right? Baseline of the kidney, the hemoglobin, the kidney function and the liver function. Okay, so now we have the TB. Then you can go for a TB culture. So normally urine culture, the urine culture takes around 2 days with the ABST another day, so 3 days total. But TB culture takes around like 6 weeks. It's a very slow growth bacteria. So the slow growth is one of the advantages of it for survival in the lungs as well. So also you can the drug course that we give for TB anti-TB drugs, it contains rifampicin as an antimicrobial. So in this gene expert thing, we can also check for rifampicin resistance. So I think antibiotic sensitivity testing can also be done in the culture, but for this PCR, that is a lifesaver. You can just get the details in like 2 hours. Okay. So even in that, so PCR you get like the viral load also. Acid 5 bacilli you can also get like how many bacteria in a field, how many in this number of fields. Like there's a grading scale for acid fast staining too. Anyhow, so what else? Also the most commonest investigation for TB is this normal chest X-ray. Very nice, like even for like foreign countries when you're going, sometimes they request this chest X-ray. So in the chest X-ray there will be like upper and upper middle lobe consolidations, cavitations sometimes. This diffuse appearance, collapses, fibrosis, these things. So if they're in the upper lobe, the middle lobe, could be TB, but but the first thing you will say if there's a consolidation in the lower lobe. Could be TB, but could be a community acquired pneumonia. Yeah. Not the first diagnosis for a case of consolidation in the chest X-ray on a lower lobe. Okay. What else is chest X-ray? The chest X-ray is very useful for this thing that the community screening we do. So at the high risk people we do this community screening. So if you have a portable, you have to have a portable X-ray machine. If you can get a portable X-ray to work, and when you screen the people with like 1 to or something, and chest X-ray gets positive after the chest X-ray is not the first investigation, I don't think. But if you get positive, yeah, could be enough for further investigations. Alright, next. Then chest X-ray we did gene expert sputum culture. Now we have to go for MAN2. Okay, what is MAN2? MAN2 is this protein, that's this protein we get from this so there's this tuberculin protein we get from the tuberculin bacteria, and we just inject it to the patient on the left or the right limb, anterior aspect, normally in the forearm, and within 42 to 72 hours we check for induration. Induration means you get a little lump. If it is more than 10 mm diameter, probably you have been infected with TB before. So infection does not mean disease, but you have been exposed and the TB bacteria is in your body. Okay, the next thing, there's this thing called CY-TB, right? CY-TB. So it is a better test than MAN2 because MAN2 can even get positive for this BCG vaccination. BCG is given to this small, but just after born, when you are going out of the hospital, you have to get a BCG vaccination because TB is very bad for the child. So, but MAN2 can get positive even for BCG. But the CY-TB will not. The CY-TB immunization limit is like 5 mm. So if it gets 5 mm, it is positive. BCG does not matter. Immunosuppression, those things can also interfere with MAN2 but not with CY-TB. Okay, so the thing is for MAN2 and the CY-TB, these things, you have to come can't remember whether CITB is just the protein or the another name for MAN2. I can't remember the categorization, but two things there are, okay. Then the thing is, for this MAN2 test, the patient has to come, the client has to come 2 times now, because first time for the induration, first time for the injection, second the inoculation, second time for the reading. We can do this thing called IGRAS test, immunogamma releasing assay, I think. So IGRA is a test we do for the serum, blood serum. So we can get the serum from the client and do a single test, a single step test in the lab and check for this interferon gamma release. So when the TB infection comes, we said that the TB bacilli lights, so they go up in the lung. There's decreased mismatch ratios, all those things, right? Also like lower white blood cell infiltration things. Then it makes this granuloma, right? And what TB makes is caseating granuloma, and it lies dormant in there. Also, now there's some information and things. No, so the body is releasing, the immune cells are releasing interferon gamma. You can check that using IGRAS. So IGRAS positive, you have TB inside you. Okay. What else? Investigating for TB. So screening we do for high risk groups, right? Like if we have contact TB, because we have contact with a TB infected, TB diseased person. Yeah. The thing is, if a patient is not getting treatment for TB, if they have ongoing TB infection for a year, they will infect around 10 to 15 people. So that's a lot. So we have to treat. Okay, next thing. So treating. So there are 4 drugs. 4 drugs for 2 months, 2 drugs for 4 months. The 4 drugs are the rifampicin, isoniazid, pyrazinamide, and ethambutol. So right, they have this HRZT, and HR2, HR4, 2 HRZT and 4 HR. But I like RIPE and RI. So those are the 4 drugs. So you have to take them for like 4 drugs for 2 months and 2 drugs for 4 months, and after 6 months, if you take the drugs daily, yeah, you're good. So we are giving all these things are antimicrobial. So we are giving this much of antibiotics because we are afraid of this drug resistance. So like our antibiotics are limited now. So if we get overpowered, then we are go. We are done for good. So because of that, we have to. I'm saying again, we have to adhere them for being compliant. So there's this thing called direct observed treatment. So we allocate someone from the community or within the house or a PHI or somebody. So they will see that the patient is taking the drug. Sometimes they may not be compliant, sometimes they may just forget, sometimes they may be dementic, like old people get this thing, no? Right? So they have these note cards, they have to sign these things. Okay. Then MDR-TB. MDR-TB is multi-drug resistance TB. This is very bad condition when the patient is not compliant several times, or they could also, and when you come into contact with someone like that, you get MDR-TB. We have certain line drugs, but it is very hard to treat. Normally we take them in-house, in-no treatment, because we can't risk this thing, no? So WHO says that Sri Lanka is supposed to have like 15 catches of TB we are only getting around 9,000, 9 to 10,000, so we are making like 5,000 of TB infected or TB disease, right? Yeah, TB disease people. Yeah, so we have to monitor. So there's this book the OPD called like it is a presumptive TB. Like we do not know whether they have TB. We have not done any investigation, but like we think they might. It'd be better to check them out. So we just register them in the book and do these things. The district testing clinic. What else in TB? So in the chest X-ray, if we can't directly find a cavitation, we're not. It is showing very diffuse, let's say, diffuse opacities or diffuse consolidations. So then we can go for an CT. Like they will come with a nice report with granulomatous cavitation and blah blah blah. And we have to screen these prisoners. They are very high risk groups. Prisoners, garment workers, these people. And with the medication for this TB, so the pediatric dosage and pediatric medications are different, alright? So the rifampicin can make your urine orange color, and some of these things are like can have toxicities. So we have to get a baseline, and we have to monitor those baselines. And if toxicity was to come, then toxicity or a drug reaction was to come, then there are some specific protocols to how to act on it. I can't remember now, but yeah. Also, what else? The healthcare workers are at more risk. Normally they say around 1 in every 4 is TB infected. TB infection as a disease. The infection means the bacteria is in the body when it's like lightly. If we are taking lightly, the bacteria is in the body. The disease means you are like having active TB disease. There's a thing called latent TB, like the TB is dormant in the body. And there's this thing called miliary TB. It is like a extrapulmonary TB. Could be in the liver, could be in the vertebrae, could be in the kidneys, could be even in the the pleural fluid. So if it is in the pleura, it is most of the time it is extrapulmonary, so not infective, unless I don't know, you have exposed pleurodactyl, I guess. But if it is from pulmonary and they have somehow inhaled into the pleural cavity, so that is disseminated. So that is very bad. So miliary TB normally we diagnose with a biopsy, right? We do CT guided biopsy, this interventional radiology things, that is. So TB can also go into the brain. So CSF, normally we send the CSF culture when taking CSF samples. Yeah, I think that is it about TB. Thank you for listening. Finally, caring for a TB patient, like you have to have good ventilation. It's better to wear masks. Like always, the good ventilation is a best practice, right? Even in the clinic, we have very good ventilated areas. Yeah, ventilation is the best. Please do not get TB. Like if you have enough immunity and you are not immunosuppressed and those things, like even though you have the TB infection, you may not get TB disease. And if you are infected with TB and you get immunosuppressed, the active TB can be deactivated. So HIV, prednisolone, those things can precipitate active TB. Okay, don't get TB.